Thank you for your interest in the Rural Health Clinic program. You have accessed part 2 of the 4-part session entitled Rural Health Clinic Billing. The Rural Health Clinic Billing session is designed for individuals who may not be familiar with the Rural Health Clinic program and its unique billing requirements. For additional information about the RHC program, please access parts 1, 3, and 4 of Rural Health Clinic Billing, as well as other focused educational Rural Health Clinic webinars sponsored by the Wisconsin Office of Rural Health. Rural Health Clinic Billing, Part 2, Billing for Rural Health Clinic Services. Rural Health Clinic encounters. RHCs are able to bill for each face-to-face medically necessary encounters with an RHC-defined practitioner. And RHC-defined practitioners are physicians, nurse practitioners, physician assistants, certified nurse midwives, clinical psychologists, or licensed clinical social workers. So in order to bill for an encounter, you need to be thinking, do I meet the 3 criteria? Is it face-to-face? Is it medically necessary? And is it with a RHC-defined practitioner? There's many services that you may perform in a rural health clinic setting. However, not all services provided within the RHC are considered RHC services. You may provide non-RHC imaging or other diagnostic services where the technical component of those diagnostic services are considered non-rural health clinic services. You may also have providers that spend time in the hospital and they may cover the emergency room or do inpatient rounding. That's not considered RHC services either, even though they may be considered RHC providers. That time in the hospital is not considered RHC time. Non-covered services, if it's a service that's non-covered just because it's in an RHC, doesn't mean it's a rural health clinic's billable service. If it's non-covered anywhere else, it's not going to be covered in a rural health clinic setting. And then, of course, we have the 6 required lab tests that as a condition of participation in the rural health clinic program, the clinic has to have the ability to perform. However, all lab services, those 8 series codes, are actually considered non-RHC services, and we have to bill them differently. So when we think about billing for rural health clinic services, really think about those services within the 4 walls of the RHC, and I'm going to give you some exceptions later, but within the RHC walls, with the exception of diagnostic services, the technical component of those, and lab are 8 series codes. Whether you're an independent or freestanding rural health clinic or a provider-based rural health clinics bill for RHC services the same way. They bill in a UB04 claim format, and they bill to the RHC Regional Fiscal Intermediary. So how we bill for RHC services is exactly the same, whether it's independent or a provider-based RHC. The services that you provide in your rural health clinic, again, these are considered RHC services when they are physician services or services of our non-physician practitioners. One of the benefits of rural health clinic status is we get the same payment regardless of level of provider that's performing the service or level of service provided, regardless of whether it's a 99212 or a 213. All the services and supplies incident to those practitioner services are also part of the rural health clinic encounter. If you are designated in a home health shortage area, you may bill for visiting nurse services to the homebound. And this is something that you have to have a certain designation from CMS. It's not automatic, so most rural health clinics don't have this, this designation. It's something that you have to work towards. As mentioned previously, clinical psychologists and clinical social worker services are considered rural health clinic services and can be billed and paid under the RHC all-inclusive encounter rate. And the services and supplies incident to their visits are also part of the visit. We talked about within the 4 walls of the clinic, we want to think about our RHC services. However, there are services in the hospital that may be considered RHC, and there's one instance, and that's if the hospital has swing beds, designated swing beds, and that patient is in a Part A stay, those are considered rural health clinic visits. So your providers can go over and do swing bed rounds, and you can bill that under the RHC provider number. In addition, if it's a nursing home visit, that's considered an RHC visit as well. One other instance of outside the walls of the RHC are home visits, as well as the scene of an accident. RHC billing is mentioned in another session under part 1 of our billing series. We talk about bundling services onto the first line. So for billing for rural health clinic services, we have to bill with a revenue code, which we'll go over later. We have to bill with the appropriate CPT code. We use a CG modifier for the primary reason why the patient came into our office for the service. And we bill with total charges for those RHC services bundled on the first line. For example, in this case, the patient came in for a 99213 and had a $100 charge for their service. That $100 charge plus $15 charge for an allergy injection, which was also given on the same day. Again, be thinking incident 2. This was incident to the service. That $15 charge is added to the first line, and that's what coinsurance and deductibles are going to be based off of for the patient. The secondary line includes the allergy injection and the charge for that amount, and our total charge listed on the UB04 claim format is actually inflated. Keep in mind, though, that that $115 amount with the modifier CG is what the patient's coinsurance and deductibles will be based on. Again, incident to services in a rural health clinic, those are services and supplies incident to that visit. If, though, we have incident to services furnished on a different date of service from the qualifying visit, we can actually combine those charges with a previous or subsequent encounter, and most intermediaries indicate that's within 30 days of the date of service. Or we have the ability to write off these amounts. For example, if we had a patient that had a 99213 and had an allergy injection a week later, and it was ordered by the physician, we can add those charges in and indicate that it was provided on the same date of service as the original E&M. We won't get anything additional from Medicare, but we will get 20% from the patient in coinsurance amounts. Or you have the option to write those off. And most clinics that we work with typically write those off because it's really hard to keep track of those, and what they're getting in coinsurance really isn't that much. Keep in mind that allergy injection doesn't qualify as an RHC encounter because likely a nurse is doing it, or it's not medically necessary that a physician perform that service. So it doesn't meet the 3 components. It's face-to-face, it's medically necessary, but it's not with an RHC practitioner, meaning the nurse performed the service. Preventive services in the RHC, there are certain preventive services that can be performed in a rural health clinic and get paid at the all-inclusive encounter rate. These preventive services constitute a single billable visit if they are performed with another service on the same day, with the exception of the initial preventive physical examination or the Welcome to Medicare visit. If a Welcome to Medicare visit is performed on the same day as another medical service that's eligible to be billed as a rural health clinic encounter, the clinic can actually receive 2 encounter rates for that date of service. Co-payments and deductibles are waived by the ACA for the IPPE and annual wellness visits, and for Medicare covered preventive services recommended by the U.S. Preventive Services Task Force with a grade A or B, and we'll go over that in a second. This website actually is the CMS Rural Health Clinic website, and this contains a spreadsheet of the preventive services that can be performed in a rural health clinic setting and get paid at the all-inclusive encounter rate. In this example, again, we have the IPPE with the description, and it indicates in the 4th column, is it paid at the all-inclusive encounter rate? Meaning that if this was the sole purpose that the patient came in and was the only reason the patient came in for the service on that day, would an encounter rate be paid to the clinic? Yes, it would be. In the next column, is it eligible for same-day billing? Meaning if the patient had another service on the same day, would 2 encounter rates be paid? Yes, it is. Are coinsurance and deductibles waived? Yes, they are waived. Therefore, we have to bill a little bit differently, and we'll go over that in a second. The rest of the spreadsheet is on the website, and I'll just contrast that with the annual wellness visit. So in this case, the annual wellness visit, if the patient came in for this service, it is also paid at the all-inclusive encounter rate, but it's not eligible for same-day billing, meaning if we had another service along with the annual wellness visit, we'll only receive one encounter rate paid on that day. Again, deductibles and coinsurance are waived for this service. Therefore, we need to make sure that we include these charged amounts a little differently on the UB04 claim form. Again, this spreadsheet is at the website listed at the top of the screen. So this is an example where a patient came in for a 99213 and the charge for that service is $100. In addition, a breast pelvic exam was performed and the standard and customary charge for that is $75. In addition to that, a venipuncture was performed for $20. So we know that the G0101 code is a preventive service that's paid in a rural health clinic setting. However, deductibles and coinsurance do not apply. Like our previous example, the 99213 is a sole reason why the patient came in, and therefore we append that line with modifier CG. We include the $100 charge on that line. In addition, the venipuncture charge is also added to that line, so we have a total charge amount of $120. Note that the $75 charge is not included on the first line because if we include that $75 charge, Medicare will base coinsurance and deductibles off of that first line. And we know that that code is not eligible for coinsurance and deductibles to be charged to the patient. So again, we're bundling everything onto the first line except for any preventive services where deductibles and coinsurance are not applicable. Pneumococcal and influenza vaccines. Patients can come into your rural health clinic and receive these services. Direct Medicare patients and direct Medicare patients only are not to be billed for these services. The clinic actually gets reimbursed, cost-based reimbursement for the administration, vaccination amount, and actually overhead is also allocated to these services, and it's reimbursed at the end of the year on the Medicare cost report. So clinics need to make sure that they still keep track of these services provided in total, as well as to Medicare patients, but they need to make sure that for Medicare patients, these amounts are not charged. Again, we get reimbursed on the cost report at the end of the year, and this is the only vaccination that's reimbursed that way. In order to claim these on the cost report, we need to make sure that we have a log of all the patients that were provided the service, and for Medicare patients, we need to include the name, date of service, and Medicare number for these services. These are the bill types that are used for rural health clinic claims. So typically we'll see a 711 original claim form is used for most services that are provided. However, we may have to use other bill types. For example, 718, we may void a claim. Maybe we have a 710 with only non-covered charges. But again, typically we're using that 711 original claim form for our RHC services. In addition, rural health clinics are required to use revenue codes that are often referred to as place of service codes when we're talking about RHCs. And these are the revenue codes that we'll be using in the rural health clinic. And typically, again, within the walls of the clinic, we're using that 521 revenue code. You'll also see the 522 revenue code for home visits. We also have a 524 visit for a rural health clinic practitioner in a Part A stay SNF. So that's our nursing home patients or our swing bed patients in the hospital. And I'll also mention that telehealth services, revenue code 780, although these are not RHC services and are paid differently, you actually get paid fee schedule for these services with a Q3014 code. The 780 revenue code would be used for these telehealth services for originating site services. The 900 revenue code is used for mental health visits. And this is important because you can have a mental health visit and another visit on the same day and actually receive two encounter rates on the same day. So again, these are often referred to as place of service codes because they indicate where the service took place. Typically, rural health clinics only have one visit per day with a patient that's payable. However, if multiple billable encounters are provided on the same day in your clinic, and they're unrelated as far as diagnosis, then the 2.5 or 5.9 modifier can be used on the claim form in order to bill for these services and get paid more than one encounter rates. Again, you need to make sure that that there's a different diagnosis and it's documented in the file. For example, a patient came in with a sore throat in the morning and a sprained ankle in the afternoon, completely different diagnoses, and can then bill accordingly with the 2.5 or 5.9 modifier. If the patient has a medical service and a mental health service on the same day, as indicated previously, a modifier CG should be reported on both of the lines, so the medical service line and the mental health line should be indicated with a CG modifier, and 2 rates will also be paid by Medicare. We do have a situation where you could actually get 3 rates paid by Medicare. For example, if you had the Welcome to Medicare visit, the IPPE, a mental health visit, and another medical service on the same day, that's all billable and paid by Medicare. Thank you for your interest in the Rural Health Clinic program. You have participated in part 2 of the 4-part session entitled Rural Health Clinic Billing. For additional information about the RHC program, please access parts 1, 3, and 4 of Rural Health Clinic Billing, as well as other focused educational Rural Health Clinic webinars sponsored by the Office of Rural Health.